Hello everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar series for March 21st, 2018. Thank you for joining our presentation this month. Our presenter today is Adam Goode. He is an epidemiologist and physical therapist with a focus on musculoskeletal epidemiology and health services research at Duke University. His clinical interest is in the treatment of low back and cervical spine pain, and his research interests are in lumbar spine degenerative changes, low back pain, and surgical outcomes in health services for cervical spine fusion. Welcome, Dr. Goode.
Well, thank you, Kirsten, and thank you to the OAAA Action Alliance for the opportunity to speak here today. On behalf of my co-authors, collaborators listed here, I'll be presenting some work that we completed here recently on physical activity for older adults with chronic low back pain. And this was a collaboration between the Durham VA, Duke University, and UNC Thurston Arthritis Center. So all the authors have no disclosures related to this work. And many of us know that low back pain is a very prevalent condition. As many as 39% of the population will have low back pain at some point in their life. However, among older adults, almost half will have low back pain or complain of low back pain at some point during being an older adult. Within the Department of Veterans Affairs, chronic pain is a very prevalent condition, and low back pain is one of the most common reasons for that complaint of pain. Physical activity is a simple intervention that can be used to improve physical function in older adults and can be successfully delivered in a home setting, with older adults being able to complete that safely. And cognitive behavioral-based therapy approaches such as that for pain are associated with improved outcomes for low back pain and can be adapted to a wide range of clinical settings, including telemedicine. Despite guideline recommendations for these interventions, there's a lack of studies that examine these alone or in combination for the older adult population with chronic low back pain. So the purpose of the study was to conduct a pilot study to examine a home-based telephone-supported physical activity program that was done alone or in conjunction with a telephone-delivered cognitive behavioral-based therapy for pain intervention among older adults with chronic low back pain. So a little bit of the overview of the methods and setting. It was a single-blind, randomized pilot feasibility trial that was approved by both the Durham VA and the Duke University IRB ethics committees. Baseline follow-up assessments, however, were conducted at the Durham VA Medical Center by a research assistant blinded to the assignment. And following baseline measures, older adults, which were defined as age 65 years or older, were randomized with equal allocation to one of three arms: a physical activity arm that received only an exercise-based program, physical activity plus cognitive behavioral-based therapy for pain arm, and then a waitlist control arm. Participants then returned to the Durham VA 12 weeks later for follow-up assessments, and the participants received $30 for each visit for their time and travel. To be eligible for the study, the participants had to report low back pain for most days for greater than 3 months, had to be sedentary, defined as less than 150 minutes per week of moderate physical activity. They had to be able to complete a 10-second semi-tandem stand and walk 8 feet in 6 seconds. This was for the purposes of to be able to safely complete a home exercise program. They had to report that they were not satisfied with their current state of functional ability, and we used the satisfaction with physical function scale for that. And they had to be able to safely participate in an intervention that was based at home, and we used a physical therapist baseline examination and their clinical expertise to determine that. We did exclude participants that had unilateral or bilateral sciatica for the most part, so that we didn't exacerbate any of their symptoms with physical activity. We excluded dementia, some other motor neuron diseases, some active inflammatory diseases, recent hospitalization, significant hearing impairment because we use telephone for communication, psychosis, and then any other conditions that the study team felt may impede their ability to participate in the home exercise program. We did identify participants through medical record. We mailed them an introductory letter and then screened by telephone for inclusion, where they could be directly referred by their physician provider at the Durham VA directly into the study. So some of our methods for the interventions consisted of all participants receiving a baseline physical exam by a physical therapist, and then an exercise program to be completed in the home setting. Both of the physical activity and the physical activity plus CBT arms of the study received telephone calls by either the physical therapist or an exercise counselor. The physical therapist would make a phone call approximately every 4 weeks, whereas the exercise counselor was a little bit more frequent, every 2 weeks. The purpose of the physical therapist calls were really to check up on exercise progression and safety, make sure there were any issues related to exacerbations of pain. The exercise counselor also progressed exercise, but also was cross-trained to deliver the cognitive behavior-based therapy intervention. The exercise program was tailored along what was found during the physical exam by the physical therapist. It did have 3 main components, though. Those were a flexibility stretching program, a strengthening program, and an aerobic or physical activity program of the participants choosing. And so although there was a standard set of exercises, these were tailored somewhat to the starting point for the participant, and each participant got written instructions and pictures of the actual program itself on that baseline visit. They also received an exercise video, Take Control of Exercise, as a low-impact video of some exercises they could participate in the home setting. So the education on progression was done initially at that baseline visit, but then there was also fostered throughout the telephone calls during the 12-week program. And this table here provides you some ideas of the different types of exercises that were given during that baseline visit. So the participants that were randomized to the physical activity and CBT group also received written instructions on CBT for pain. And like I said before, these skills were then woven into each telephone call that was delivered by the exercise counselor. The topics included pain that relates to barriers to exercise, managing pain. The table here also describes in a little more detail of the different types of CBT for pain that was considered our skills that were delivered over the 12-week program, ranging from activity pacing, breathing relaxation, distraction, progressive muscle relaxation, and cognitive restructuring. They did also receive a CD that contained information on relaxation, so they could listen to that at their choosing. The waitlist control group was instructed to continue their current lifestyle over the next 12 weeks. They were given the opportunity to choose either group, the PA group or the PA plus CBT group, following the 12 weeks on their return visit to the Durham VA. Our baseline measures consisted of demographic and clinical characteristics. We included the NIH Task Force on Low Back Pain Minimum Data Set, which measures the low back pain burden on individuals. Our 2 primary outcomes were physical function related. One physical performance measure, the timed up and go, and then also a self-reported measure, the Promise Hack, as our 2 primary measures. Some secondary measures that we report today, the Rowan-Morris Low Back Pain and Disability Questionnaire, which is a very common legacy measure of low back pain and its disability, the Satisfaction with Physical Function Scale, and the Coping Strategies Questionnaire were 3 that we'll report here today as being secondary outcomes. We were particularly interested in adherence and feasibility, considering this was a pilot study, and we did measure that with the number of telephone calls that were completed throughout the 12 weeks, and of course the number of participants that completed the study as a measure of adherence and feasibility. Our analyses consisted of descriptive statistics of baseline characteristics and across study groups. We used linear mixed effect models for between group analyses. We focused on effect size because it was a pilot study rather than focusing on statistical significance. And so although we report the p-values, we're really focused on the effect sizes for a larger study down the road. Some of our results. For feasibility and acceptability, like I said before, we really focused on completion and then number of phone calls. Overall, 50 of the 60 participants completed the study at 12 weeks, 19 from the physical activity group, 16 from the physical activity plus CBT group, and then 15 of our waitlist controls completed the study. We did measure adverse events by self-report, and no participants reported any self-reported events as a result of the study. The average number of intervention calls, there were 13 possible phone calls that could be completed by the participants, and in the physical activity group, it was an average of 10 phone calls. In the PA plus CBT group, that was around 9 phone calls. When we looked at the number of phone calls completed when we removed the withdrawal participants, then it was fairly similar, around 10 completed phone calls for those groups respectively. This just gives you an illustration of our flow of participants in the study. We did identify around 1,500 participants through the VA medical records, and we did have non-physician consults that were sent directly to the study. We did have 10 participants of the 71 that were screened eligible that refused or no-showed, and we did have one that consented into the study that did not pass the physical therapist exam. We randomized our 60 individuals to those three groups, and this gives you an indication of the withdrawals and loss to follow-ups and drops from those three groups. This is a busy slide. This is just our baseline demographics and characteristics from those 60 individuals. We didn't find any differences across groups, and so our mean age is 70 years old. And although we did try to recruit, increase recruitment of women into the study, the VA population, there was predominantly more men. Majority were Black, African American, or white, and non-Hispanic or Latino. Most had some education, and there were some that were considered themselves on employment status of disabled. But for the most part, there was a fairly equal distribution across our study arms of those characteristics. Another busy slide of our results of within group and between group. The first column on your left is the actual measures for our primary and secondary outcomes that reported. The second column is our within group changes from baseline to 12 weeks and then 95% confidence intervals. And our between group changes on the next column and then the effect size. For time, I'll just focus on our between groups between baseline and 12 weeks. As you can see, for our timed up and Goode, when we compared between group of our physical activity and PA plus CBT, we found some similar results when compared to the waitlist control with small effect sizes and a very minimal effect when we compared physical activity directly to the PA plus CBT. For the PROMIS hack, our self-reported physical function measure, we did find some medium strength effect sizes for when we compared physical activity to the waitlist control. And however, for when we compared PA plus CBT and PA to PA plus CBT, we didn't find but small to medium effect sizes for those to comparisons. For our secondary outcomes, for the most part, we found small effect sizes for both the satisfaction with physical function and also the coping strategies questionnaire. For the Rowland-Morris Disability Questionnaire, which is a disease-specific for low back pain, we did find that among the physical activity group, there was a medium effect size for in comparison to weightless control, but really small effect sizes when we compare the physical activity plus CBT to waitlist, or when we compare the two intervention arms to each other. So a little bit of discussion about our findings. This was a single-site pilot feasibility study. We did find that older adults that were sedentary at baseline and that reported dissatisfaction with their physical function had small to moderate effect size improvements in physical performance and self-reported primary outcomes. It was a feasible study when we look at the number that completed the study and also that completed the rate of phone calls. With our secondary outcomes, we found that self-reported low back pain specific physical function had a moderate effect sizes for our physical activity group. However, although we hypothesized that the addition of CBT for pain would have an improvement over PA alone, physical activity alone, we didn't find that to be true in any of our groups for any of our outcome measures. So this was, in conclusion, it was a single in-person visit with a physical therapist followed by a telephone-supported home exercise program was feasible. It produced small to medium effect sizes on physical performance and self-reported disability among older adults with chronic low back pain. And this is important considering the large number of older adult veterans with chronic low back pain. It's a very prevalent condition in the general population and the VA. It is a telephone-supported exercise program. It can be a practical mechanism given the demands for physical therapy services in the VA and access for rural VA facilities and veterans who live at a distance. However, these findings are preliminary and a large clinical trial is needed to fully assess the effectiveness of interventions that we examined. I'd like to acknowledge my co-authors listed here for their contributions and help with the study and with getting the paper together and results for the presentation. Also, I'd like to acknowledge the Durham VA Medical Center, especially the Health Services Department and the Ambulatory Care Service for referrals and their help with writing the grants and the papers for the work that we presented here. I'd like to acknowledge that this work was supported by the Department of Veterans Affairs Rehabilitation and Research Development by a grant number listed there, and also by the Center of Innovation for Health Services Research in Primary Care at the Durham VA Medical Center. And like Kirsten mentioned, I'd like to thank the American Physical Therapy Association for their efforts. This work has been accepted for publication in Physical Therapy Journal as part of a special issue on pain management that will come out in May. It is under embargo, but they've been working with us for this webinar and the results that are presented in the webinar. So a special thank you to the APTA for promoting this work. And I'd like to say thank you everyone for attending, and if you have any questions, feel free to ask.
Thank you, Dr. Goode.
Yeah.
And like you said, we will open the session for questions. Go ahead and type your questions into that chat box in your lower right of your screen, and we will be happy to address those. So in the meantime, I think these findings are interesting and encouraging. I mean, certainly, I think I preach to the choir with a lot of folks on this call who know how challenging it can be to get people to be physically active. You know, certainly when you have pain conditions, chronic conditions like low back pain and osteoarthritis. I think your findings are encouraging, certainly, and as you recognize at the end, it's a small sample, and a larger clinical trial would be interesting to see if these results hold up. Do you have any thoughts about what that next step might look like in terms of a larger trial, or any plans in the works or something like that?
Sure. I mean, I think that we have talked some about some next steps related to scaling the project, either as it is or as part of another study. And of course, Kelly Allen, who is the PI and senior author on the work, and I have been talking about what that might look like. At this point, we're still in discussions about what that would be, and if that would be part of another study, part of a component of another study, or if it would be a study of itself, a bigger study of itself, how we presented it here.
Great.
I think there's another
I think that would
question.
be.
Oh.
Mm-hmm.
Oh.
Yeah, so Sharon Wrighton, can you describe some of the specifics of the cognitive behavioral therapy?
Sure. I think that, to give you an idea, I kind of went through that fairly quickly, but the idea was that we would focus on some CBT skills that were specific to managing pain, and I think that we took advantage of a cross-trained exercise counselor that could deliver some of those skills over the phone, who had also delivered those skills in a separate study. But for the most part, I brought back up the slide here that describes in detail some of the CBT skills that we had originally designed into the study that are, fairly, I think, in the basic area of CBT for pain. So I think that, some specifics, I'm not sure exactly how specific, but, we can also provide more details, if you'd like, on any specifics of delivery or the components that will be mentioned in the paper as well.
Yeah, and taking off from this point, I think I was a little bit surprised in your findings that there wasn't more of an effect with the CBT group, if I understood that correctly. I'm thinking in terms of, folks who are sedentary and have chronic pain. It could be that there's a lot more in terms of barriers to getting them to be physically active than simply the pain. And certainly CBT suggests that, there are skills that folks can learn and employ to help them overcome some of those barriers.
Right, and that was a part of our original hypothesis, is that group with that added skill would have greater effects for improving physical function compared to the PA alone. In thinking of some possible reasons, with older adults, it could be that focusing on one aspect at a time may be more important. Also, that we didn't recruit based upon those who had poor coping strategies, so it could be that our groups didn't have a large amount of folks who could have benefited greatly from a CBT type of study. So, there's a couple reasons. There has been another back pain-related study that didn't show an increased effect from CBT when compared to a PA alone type of design like this. So it was a little bit surprising to us as well. But again, it was a small study, so we can't really say definitively that it wouldn't increase the effects done in a larger group.
Yeah, I think that would be interesting to explore a little bit more. I was also thinking, of course, because we are from the Osteoarthritis Action Alliance, and I am professionally curious, in terms of any overlap, you certainly highlighted your patient population excluded systemic rheumatic diseases. Did you see any or hear of any anecdotal overlap with osteoarthritis, and whether or not other pain beyond simply low back pain might have confounded people's ability to be active or kept them from moving more than they were?
Sure. In the older adult population, there's certainly multiple comorbidities present, and I think that for the most part, I was pleasantly surprised at the enthusiasm for exercise in general, and just in speaking with participants as they return for the follow-up visit, how many were engaged with the exercise program and enjoyed the phone calls as reminders and as ways to increase their compliance with the exercise program. I don't think that we didn't run into any individuals that specifically had an inflammatory event or had OA that had limitations in participation. I think mainly because at the baseline visit there was quite a bit of a focus on making sure that physical therapist exam would identify any barriers meaning related to participation based upon specific joint of pain or muscle weakness or functional ability. So it could be that we tailored it to be able to address that from the get-go, so that those exercise programs were initially tailored and then progressed based upon a mutual agreement between the therapist and the participant of where to start and the idea of what is progression of exercise. So I'm not sure. I hope that answers your question. But,
Yeah, and I think that's so important to be able to tailor and then work directly with patients, getting feedback from them and continuing throughout to tailor. Because I think, even when we try to get folks to be physically active and give them a variety of ways to approach it, I can imagine that people are still a little bit scratching their heads or fearful, uncertain about how to begin. So I think it's really helpful to have programs like this. And you said something earlier that I thought was encouraging, that you were pleasantly surprised about the positive feedback about physical activity and being active. So that's extremely encouraging, and I think speaks to this kind of a program where you can get some one-on-one conversation with the patient directly and be able to address some of those issues. And I certainly know from prior work in chronic pain research that patients like to talk, and sometimes they want someone to speak with about these issues. So I think there's a lot of promise with this program.
Well, thank you. I think that a good aspect, well, there are a lot of good aspects, but one of the aspects that was related to the physical activity is that component of the program was, it could have been as very simple as walking to the mailbox and progressing from that point on, and so it was very much tailored program in that aspect, and then moving up towards some more structured walking and going to the local high school and walking around the track and so forth like that. So I think that did help with some of the compliance related to the study and the outcomes.
Great. Yeah, and go ahead. I'm sorry.
Sorry, there was just one more question there, but if you want to finish your thought.
Oh, yeah. No, I was just going to say, as we get into that last question, I just wanted to note that we are officially at the end of our 30 minutes. We will answer this question, but just wanted, for anybody who does need to sign off, to thank you again for joining us today, and check us out next month on the 18th of April. I'll put that information here in the chat box, but for the time being, let's go ahead and get that question, the average length of your phone calls.
Sure. Yeah, the average length of phone calls I don't think we actually measured them precisely, but for the most part, 10 to 15 minutes was what it took. The physical therapist phone calls were a little bit shorter because they really hit the highlights of, how are you doing with the exercise, and are you having any increases in pain and so forth. If there were changes in the exercise program, those calls would go a little bit longer, but for the most part, they were the physical therapist calls were fairly short. I'd say 5 to 10 minutes. The exercise counselors were a little bit longer, especially if they were in the CBT group, which had the added component to that phone call. But I think for the most part they were brief, I could say, yeah, I would think, but I don't have an actual mean length of the phone call.
I think that's helpful. Certainly I think it's a lot of times up to the therapist to stay on track with those phone calls, and patients are very willing often to share their experiences and, be happy to explore new avenues and ways to tweak the program. So I think it's important to keep those focused in terms of, looking at the physical activity and exactly what it is you're trying to accomplish. So, but that's helpful. Thank you.
Mm-hmm.
So at this point, it looks like we don't have any additional questions that have come in. So once again, I wanted to thank everyone for joining us today, and especially thank you to Dr. Goode for your presentation today. And we'll look forward